Welcome back to the second session of our program today. This second session is going to focus more on the potential mechanisms that will create the problems that we will see that are part of long COVID, both those that seem like myalgic encephalomyelitis, chronic fatigue syndrome, and those that seem like fibromyalgia. We have three wonderful speakers that will be presenting to you. The first presenting long COVID and ME/CFS overlap and insights is Ian Lipkin, who is the director of the Center for Solutions for ME/CFS, the John Snow Professor of Epidemiology at Columbia University, Vallagos College of Physicians and Surgeons, and the director for the Center of Infection Immunity within the Mailman School of Public Health at Columbia. He is an internationally recognized scientist for his contributions to global public health, with critical advances in replacing culture-dependent methods of global health management by creating new criteria for disease causation and delinking spurious associations between putative agents and diseases. Such examples include refuting the MMR vaccine having a role in autism and refuting the role of XMRV in myalgic encephalomyelitis chronic fatigue syndrome. Dr. Lipkin has been at the forefront of outbreak response to many of the world's most recent outbreaks, including West Nile virus in New York City, SARS in China, MERS in Saudi Arabia, Zika in the US, and encephalitis in India, and most recently, COVID-19. Daniel?
Yeah, then we will move to the second presentation, how SARS-CoV-2 damaged the brain. For this talk, we have the pleasure to have Thiago Cunha, who holds a PhD diploma is an associate professor at the Ribeirão Preto Medical School at the University of São Paulo, where he works to understand the cellular and molecular mechanisms behind pathological pain conditions, focusing on neuroimmune glial interactions. The final aim of his studies is to find novel molecular targets that could be useful for novel drug development. Among the main contributions from his lab to the field of pain are studies concerning the pro-nociceptive role of cytokines, chemokines, and complementary systems. Then, please.
Finally, our third speaker, presenting musculoskeletal pain after COVID, a new fibromyalgia-like condition, is Serge Perot. Serge combines an academic activity as a professor at Paris Descartes University with his clinical work as the head of the pain center at the Cochin Hotel du Hospital in Paris, France. His clinical work and research are focused on musculoskeletal pain, osteoarthritis, rheumatoid arthritis, fibromyalgia, neck and low back pain. And with no further ado, let's start with the presentations.
Good morning. Thank you for the invitation, Brian. The pathology of COVID-19, the causative agent, of course, being SARS coronavirus, reflects the receptor distribution of ACE2. It's widely distributed on epithelial cells, endothelial cells, astrocytes, and oligodendrocytes. As a result, the pathology is ubiquitous. So although we typically think of it, or early in the course of the pandemic, we thought of it primarily as a pulmonary disease, we now know that it involves a wide range of organ systems. And the pathogenesis reflects to some extent direct parenchymal damage, but also inflammation, damage to vasculature, and thromboembolism. So as a consequence, you can have permanent disability as well as disability which is more transient. And we'll be focusing primarily on the latter. Even after you get resolution of the damage associated with acute disease, many people have lingering symptoms. This is some early work from March through June of 2020, as reported by the CDC. And as you can see from the figure, many people have continued fatigue, cough, headache, body aches, and so on. Some of this reflects damage directly to tissues. Other appears to be due to ongoing inflammation and even potentially some metabolomic disturbances about which we'll be talking shortly. I had COVID myself in March of 2020. And at that time, my initial presentation was with a splitting headache. And as you can see here, headache remains a prominent problem. My symptoms largely resolved over a period of several weeks, but there's still some residual fatigue, which I feel, which requires that I moderate my activities. There's been some later work that's reported here, August through November of 2020. Here we're looking at sequelae in adults 6 months after infection. The most important point that I want to highlight here is that many of the individuals who report lingering symptoms were not even aware that they had COVID, this infection with SARS-CoV-2. So the actual diagnosis was made retrospectively using laboratory tests. 6% of these individuals were asymptomatic, 85% had only mild disease, and as you can see, a very small fraction were hospitalized. And these individuals were reporting continued complaints 9 months after infection. And there's a wide range of organ systems that are involved. But again, you can see here that one issue, of course, which persists and it becomes a huge problem is fatigue. Now, many people talk about dysgeusia and anosmia, where you see this loss of taste or smell. This is a very, very prominent complaint, but more troublesome still, of course, is the persistent fatigue and in some individuals, cognitive dysfunction. Although I've shown you data from the United States to date, there are similar reports from other parts of the world. This is work that was done in Germany, again with a prospective cohort. And as you can see, many individuals had continued disability. Some followed as far out as 7 months. Shortness of breath, anosmia, problems with taste, and of course, fatigue. And 11% of the individuals in that cohort were unable to pursue activities essential for everyday life or to work 7 months after disease onset. And this has led to the issue, of course, that many people are concerned that this is a tsunami of disease that will cause persistent disability globally for a long time to come. The take-home points from the first part of my talk are that SARS-CoV-2 infection can result in long-term disability, even in people with mild or no apparent acute disease. Therefore, if you suspect that this is the problem, particularly as we begin thinking about ways in which these people may be treated, it's important to consider SARS-CoV-2 infection in the differential diagnosis. What I've described thus far has been studies in adults, but children did not escape unscathed. We know less about this, and there's some questions still as to the duration of this disability. So there is work that's come out of Italy and out of the UK and Australia and elsewhere suggesting that children who have mild disease, and remember that we don't even have approved vaccine at this point, for children can wind up having severe complications. And these can last for a very long time. So again, the fatigue, the arthralgias, headache, insomnia, respiratory problems, and in some states, some cases, palpitations related to arrhythmias. There are reports suggesting that most of these children will return to baseline. That's what we have reported out of Australia in the paper from the Lancet. But I think we have to say that we don't know at present whether or not these symptoms will resolve. Now, there are 2 other complications that have been reported in children who've had SARS-CoV-2 infection. One is known as a multisystem inflammatory syndrome, which was initially thought to be Kawasaki disease, which I'll talk a little bit about as well. So we know that this particular syndrome, MIS-C, can be caused by SARS-CoV-2. It's usually in children under the age of 18. Most of them have severe disease. And it typically responds to IVIG and or to steroids, and I presume would possibly respond to plasmapheresis as well, though I'm not aware of any studies to that effect. There's a very similar disorder that was described in the 1960s, which looks, in terms of presentation, analogous to MIS-C, and that's Kawasaki disease. It also follows a viral syndrome, typically a viral syndrome that is unknown. Children are typically younger, and it is the most common cause of acquired heart disease in children with coronary artery dilatations and aneurysms. It also responds to IVIG, and in fact, that is the treatment of choice. In Italy, early in the course of the pandemic, there was a report of a 30-fold increase in Kawasaki disease. This was probably, in fact, MIS-C, but I think it's worth thinking about Kawasaki disease because this is a disorder that is frequently underappreciated and is treatable. What I've tried to do here is to use a Venn diagram to illustrate the similarities and differences between long COVID, MIS-C, and Kawasaki disease. And you can see here that what they all have in common is fever. With MIS-C and long COVID, you may get fatigue and headache. There is a specific rash, which I'll show you in a moment, which is characteristic of Kawasaki disease. This is work from Jane Burns, the director of the Kawasaki Disease Center and a professor at UC San Diego. And what Jane has tried to illustrate here is the characteristic findings in children with Kawasaki disease. So you can see the injected conjunctiva, the rash, the enanthem, the swollen lymph nodes, and this rash which occurs not only on the trunk, but also on the feet. This is a very serious illness, and if you see it, please do remember that these children will respond typically to IVIG. And if they don't receive adequate treatment, then the vasculitis involves the coronary circulation and can cause severe disease and even death. I'm going to shift now to talk about a syndrome that has features in common with long COVID, known as myalgic encephalomyelitis chronic fatigue syndrome. This is a clinically diagnosed disorder for which we do not yet have laboratory tests, but we hope that we will have them in the not too distant future. The Institute of Medicine registered a series of signs and symptoms, which I'll outline here because I think it's important to realize that the fatigue is quite characteristic. So these people have a reduction in their ability to maintain their activities of normal living. They have profound fatigue, and what's interesting about the fatigue is that it may not peak immediately after exercise. It may actually peak later, several hours later or 1 to 2 days later. Sleep is not refreshing. Frequently, they'll have cognitive impairment that's described as brain fog. They also have orthostatic intolerance that may manifest with palpitations and tachycardia. There are immunological abnormalities that are characteristic. Many of these individuals have what appears to be an elevation in type 1 cytokines, and there are specific metabolomic disturbances that I'll just share with you as well. There are a number of infections that are associated with something that looks like ME/CFS and may in fact cause it. Infections with Epstein-Barr virus. It looks like a sort of a chronic mononucleosis. In Oceania, particularly in Australia, you see this Ross River virus infections and sometimes infections with Coxiella burnetii. There are reports of people developing an ME/CFS-like symptom after infections with coronaviruses, SARS, as well as MERS, and there are even some suggestions that hemorrhagic fevers may also be followed by a disorder of this sort. We and others have looked for direct evidence of infection with other herpes viruses, enteroviruses, rubella, fungi, bornoviruses, mycoplasma, and retroviruses, and have not been able to confirm any sort of association. There's another disorder known as Gulf War illness that affects veterans who were sent over to Kuwait and to Iraq. We still don't know the cause of this disorder, although obviously it's been a few decades since it first appeared. What we have noticed that many of these veterans received multiple vaccinations within a very short time frame, suggesting that there might have been some activation of the immune system, which was triggered by that. There were also some individuals who were exposed to a variety of toxins and antidotes to various toxins, and there were fires and other sorts of things. But many of these people meet the criteria that are typically used for the diagnosis of ME/CFS. And this Venn diagram illustrates those similarities and brings in as well long COVID. So with ME/CFS, many people have a prodrome that looks like a viral infection. They'll have pharyngitis, lymphadenopathy, complaints that sound like irritable bowel syndrome. They'll report exacerbations in allergies. They may have hypersensitivities not only to chemicals, but also to sounds, and they frequently will have sleep disturbances. Gulf War illness, which I'm showing there as well, can look very much like ME/CFS. And long COVID, it's important to separate those individuals who have persistent structural damage that results in shortness of breath from those individuals who have something that looks more like ME/CFS. Nonetheless, there is an overlap in each of these syndromes. And in our center at Columbia University, we study people who have ME/CFS and long COVID and Gulf War illness because we believe that as we understand one, it may provide insights into the other. I'm just going to show you a few findings that relate to work that we've been doing in the laboratory. As I reported earlier, we frequently will find evidence of abnormal levels of cytokines. In this instance, we were using proteomic approaches to examine the spectrum of proteins that might be associated with ME/CFS. And our findings that were reported last year suggested that there were sort of an antigen-driven clonal B cell expansion. And this is important because if we can identify the stimulant, we might be able to remove it and thereby have a positive outcome in the course of disease. Similarly, we might be able to use kinase inhibitors. So this sort of work is not useful only for diagnostics and for understanding the pathogenesis of the disorder, but also because it may actually lead to therapeutic approaches. Our work was replicated by another group, giving us greater confidence in the findings, suggesting that indeed there is an abnormality in activation of the immune system that might be driven by exposure to an antigen. The question then becomes, what is that antigen? We've also used metabolomic approaches. Metabolomics is a study of very small molecules that can be used as an index of what is happening within the cell. The most striking finding we had in the work that we've done is illustrated here: elevated levels of compounds known as plasmalogens, which are the products of peroxisomes. But there are other abnormalities as well. Those include elevated levels of triglycerides, various other long-chain fatty acids, evidence of mitochondrial dysfunction. One approach that we typically use as a way to bring out some of the abnormalities that might otherwise remain hidden is to subject patients to a stress test. In this case, we're placing them onto an exercise bicycle. We ask them to go as hard as they can for as long as they can. And then 1 to 2 days later, we look at the impact of that stress on PBMC, which is the only thing that we can readily access from living patients. So what we do here is we collect PBMC before we do the exercise challenge, and then 24 hours after the exercise challenge. Those PBMC are immediately placed into a medium so that they can continue to grow, and they're exposed to a variety of stimuli. The control is the null of the no stimulant, but we use LPS or poly-IC or staph enterotoxin B or Candida albicans as a way of asking whether or not some sort of a microbial challenge superimposed on the stress might have an impact. And what we find here is that for the pre-exercise tolerance test cases and the post-exercise tolerance cases, they are higher in terms of their response to Candida and to Staphylococcus enterotoxin B than the controls. So if you simply compare the red bars, you can see the cases, and the blue represents the controls. There isn't any dramatic increase from pre to post exercise, but there's an elevation in the cases relative controls that is consistent, whether we're talking about Candida or we're talking about Staphylococcus enterotoxin B. We've also looked at the metabolism to get some insights there. And here, as many of you remember, the TCA cycle. What we're doing here is to measure various compounds that we would expect to be either decreased as a function of proceeding through the TCA cycle that generates ATP. So I realize that this is a very complicated slide to review, but let me just ask you to look at the different bars which you've illustrated. So you can see the pre-exercise tolerance test, and you can see the post-exercise tolerance test. Now, what's interesting is that the pre-exercise tolerance test is lower overall than the controls. So if you compare this portion of the histogram with this one, you'll see that the cases are lower than the controls. Curiously, however, if you look at the post, you'll find that the cases are higher than the controls. This is true whether you look at men and women, or whether or not you look at women specifically, or if you look at individuals who don't have any sort of evidence of intestinal complaints. And what this suggests to us is that citrate levels remain high because you blocked the procession through the TCA cycle. So the suggestion here is that in the presence of ME/CFS and exercise, there's a block in the TCA cycle that impairs recovery. Here we looked at some other abnormalities which are also more prominent. So here we're measuring a variety of phospholipids. And again, what you can see is that the individuals who have ME/CFS typically have higher levels after exercise than the controls, irrespective of what you decide to look at. So clearly, there's a problem in recovery that is not simply symptoms, but is associated with specific metabolomic and other disturbances that are associated with energy and other sorts of issues that might relate to mitochondrial damage. So what I've tried to do here is to summarize these differences that we find in ME/CFS. So the first point I want to make is that we have peroxisome abnormalities that are manifest with high levels of plasmalogen. We have abnormalities in the TCA cycle, which likely lead to impairments in energy production. Similarly, we see evidence of mitochondrial damage. Some of this is reflected by high levels of phospholipids. We have oxidative stress, which is part of that as well. And we also see inflammation. Now, I've not been able to show you the next particular feature, but we see abnormalities in the glucuronic acid pathway, which would also lead to problems with energy metabolism. And lastly, I want to mention to you that we see sex-specific effects. So premenopausal women tend to have more inflammation and more severe disease than either postmenopausal women or men. So this also explains some of the difference that we see. Now, the question, of course, is whether or not we're going to see the same thing as we begin to look at long COVID. And I suspect that there will be a wide range of manifestations of long COVID. Some will be manifestations of structural damage as a result of either direct impact on the parenchyma through infection or through vasculopathy or through strokes or other kinds of structural damage, but we will almost certainly see, as we did after SARS and MERS and potentially with other hemorrhagic fevers, that there will be a disorder that is triggered that looks very similar to what we see with Gulf War illness and to ME/CFS. Now, ME/CFS is also associated with abnormalities of the central and autonomic nervous system. I'm not aware yet that there's been any substantive studies of that sort, but I would not be surprised if we saw things of that nature. And one of the points that I wanted to make in closing is that as we begin to study long COVID, I expect that we will get insights that will be helpful in understanding ME/CFS, but it's important to continue the work that we're doing in ME/CFS because I think that will not only be useful for studying ME/CFS and coming up with solutions for this disorder that will be helpful for patients, but may also be something that we can extrapolate and extend to long COVID. Thank you very much for your attention, and thank you for the invitation, Brian.
So first of all, I'd like to thank you, the organizers, for the invitation to give this talk today, and especially ISP that is coordinating this is very interesting symposium regarding the COVID-19 and its long-lasting problems. So today I'm gonna speak about one project that we are running in the lab, in which we are analyzing what's the impact of SARS-CoV-2 infection in the brain. So, of course, my lab is mainly involved in pain studies, but when the pandemic, COVID-19 pandemic started, we decided to try to help to understand this disease, this important disease. And we decided to use our expertise in infection and brain and central nervous system to give our contribution to this area. So my name is Thiago Cunha, and I'm an associate professor in the Ribeirão Preto Medical School in Brazil. So, of course, it's very clear after this 1.5 years after the initiation of the pandemic that COVID-19 is not only related to dysfunction in the lung. So there is several extrapulmonary impacts in this disease. For example, it's very clear that thromboembolism is very frequent in COVID-19 patients. There is also dysfunction in the heart, for example, myocardial ischemia. There is a lot of data in the literature showing that COVID-19 also impact, for example, the kidney, like there is an acute kidney injury. So there is a lot of different consequences of COVID in different organs of the body. So, but also, and it's also very clear that neurological problems is also important in this disease. Even from small or very common problems like headaches and anosmia, which is very common, but also there is additional problems like strokes, and also there is some reports showing that COVID-19 patients can develop, for example, Guillain-Barré syndrome. So based on this observation and these facts, we were very interested to understand what is the mechanisms that could mediate, that could cause these different conditions in this different neurological condition in COVID-19 patients. So we have a collaboration with Clarissa Yasuda in Unicamp, and Clarissa initially decides to analyze what's the impact of COVID-19 in brain structure. So for that, she decided to analyze 81 patients that has mild COVID symptoms, and she analyzed it 54 days after the disease. What happens in the brain of these individuals? What kind of change we can observe in these individuals that recovered from COVID-19? And when she analyzed it and produced data from MRI, she observed that in a high proportion of these patients, there is some structural change especially in the cortex of these individuals. There is a reduction in the size and the mass of the cortex in these patients. And she also observed that these reduction in the cortex was associated with an increase in anxiety and depression and loss of memory, logical memory. There is a reduction in logical memory in 28% of these patients. And also another very common consequence of the COVID-19 was a reduction in cognitive function. So there is a lot of problems related to and in long-term patients with COVID-19. So when you come back to the literature to see if you can find morphological change in COVID-19 patients, this paper that came out in Lancet Neurology last year have found in the post-mortem brain tissue from COVID-19 patients that in some areas of the brain there is important change, especially in the related to, for example, microglia activation, and also there is some important findings showing that in the brain of COVID-19 patients, there is an infiltration of immune cells that could be that could mediate in this change that we have observed and in symptoms that has been observed in COVID-19 patients. So, of course, since the COVID-19 is also a systemic disease, one important question that raised was these changes in the central nervous system. They are related to change that is a consequence of this systemic disease. For example, systemic inflammation can drive this change in the central nervous system and could be responsible for these symptoms, these neurological symptoms, and these changes in structure of the brain. Or is there any signal of a direct infection of the brain caused by SARS-CoV-2? This was an important question that was raised last year, and we decided to answer this question, and we start a collaboration with Alexandre Fabro, which is a pathologist here in our school, in Ribeirão Preto Medical School. And since we have a lot of patients here in our hospital, and Alexandre is able to do some minimal invasive autopsy, we asked and we collaborate with Alexandre to perform some brain autopsies and to analyze the presence of SARS-CoV-2 in the brain of COVID-19 individuals that die from this disease. So initially, we took sample from 26 patients, and we performed this minimal invasive autopsy via endonasal transethmoidal access. So we were able to collect samples from, especially from this area here, in the A area in the brain, that we can have access to, especially to the cortex of these patients. And initially we started and we evaluate histopathological chains. And among these 26 patients that we analyzed these biopsies, we were able to find chains, characteristics of pathological chains in 5 samples from these patients. So only in 5 patients we were able to detect alterations in the brain, and especially in some cases we were able to detect necrosis in the brain. We also detect some cytopathic damage, and in some cases we're also able to also detect infiltration of immune cells, especially in the perivascular area of the brain. So since we only detect change in 5 patients, we moved forward to analyze if we were able to find genetic material of SARS-CoV-2 in the brain of these 5 cases of patients. So when we analyze the viral load, so we analyze the copies of the genomic material of SARS-CoV-2 in the samples, we were able to show that all these 5 samples, we were able to detect some signals, some significant genome material of SARS-CoV-2 in the brain of these patients. So since we were able to detect this material, we decided to move and to analyze if we are able to confirm by additional techniques, for example, by to detect antigen of SARS-CoV-2 in the brain, and also to analyze which kind of cells we could detect these antigens of SARS-CoV-2 in the brain of COVID-19 patients. So then we moved to immunostaining, immunofluorescence of spike antigen from SARS-CoV-2. And when we perform immunostaining for spike, SARS-CoV-2 spike, we were able to detect positive staining in these 5 patients. And when we analyze also, we can also perform a staining for double-strand RNA, which is a marker, which could be a marker of SARS-CoV-2 replication. We're also able to detect dsRNA in the central nervous system. And especially when we analyze which kind of cells these spike antigen and these replication sites are in the brain, we are able that these markers were expressed mainly on GFAP positive cells, which indicated for us that infection and replication of SARS-CoV-2 must be mainly on astrocytes. But we also co-stained these markers with IBA1, which is a marker of microglia in the central nervous system, and we are not detect any signal of infection of SARS-CoV-2 in microglia, but we were also able to detect infection of some neurons. Here we stained by NUN, which is a antigen of neurons. So when we quantify this immunofluorescence, as you can see here in this quantification plot, we can see that the most cells infected in the central nervous system by SARS-CoV-2 is GFAP positive cells, meaning that it's mainly infecting astrocytes, but we were also able to detect infection in neurons, but not in microglia. And also there is some infections in cells that we were not able to identify, probably endothelial cells or even pericytes that are also other cell types that there is evidence in the literature showing infection by SARS-CoV-2. So to confirm this data and also to move forward in terms of to understand what's the consequence of infection of astrocytes in the central nervous system by the infection by SARS-CoV-2, we use an in vitro model. So we develop human astrocytes in vitro. These cells are derived from iPSCs, inducible pluripotent stem cells, and we were able to generate human astrocytes in vitro, and you decide to infect these cells in vitro with SARS-CoV-2 and analyze what happens with these cells after infection. And what we observe is that after in vitro infection of human astrocytes with SARS-CoV-2, we can observe an increase in the viral load in these cells, indicating that probably these cells are, there is a replication of SARS-CoV-2 in astrocytes. So these data indicate that SARS-CoV-2 is able to infect astrocytes in vitro, confirming our data in vivo, and also there is a replication of SARS-CoV-2 in vitro astrocytes. So to confirm this PCR data, we decide to perform immunofluorescence to detect antigen of SARS-CoV-2 in these same cells. And as you can see here, 24 hours after infection with SARS-CoV-2, we were able to also to detect spike protein antigen from SARS-CoV-2 inside the astrocytes. And we were also able to detect double-strand RNA in these cells, indicating that SARS-CoV-2 is really able to infect human astrocytes in vitro, and also they can replicate in astrocytes in vitro. So we also perform additional experiments to prove that the astrocytes is able to be infected by SARS-CoV-2. And for that, we use a different approach. We use a pseudovirus. It's a VSV virus expressing the spike protein from SARS-CoV-2. And so it's a chimeric virus in which the receptor, the VSV-G protein was changed to express a spike protein. And when we infected the astrocytes with this chimeric virus, we were able to see that astrocytes become susceptible to the infection of this VSV spike, indicating again that astrocytes are susceptible cells to be infected by SARS-CoV-2. And of course, the next question of our project was, what is the mechanism by which astrocytes can be infected by SARS-CoV-2? So it's well known that SARS-CoV-2 use mainly ACE2 to infect human cells. And but there is also some evidence that other cell receptors can be targeted by SARS-CoV-2 and can be used by SARS-CoV-2 to be sensitive for infection. So initially we use a public data bank from humans brain cells from single cell RNA-seq from control and COVID-19 patients. And we analyzed the expression of different receptors for SARS-CoV-2. And as it's well recognized now in the literature, the expression of ACE2 in the central nervous system is very low in different cells of the central nervous system. But what we found very interesting is that another important receptor, neuropilin-1, which is NRP1, it's really high expressed in different cells of the central nervous system. And what came our attention is that the main cells in the central nervous system that express NRP1 is astrocytes. So to prove and to confirm this data, this single cell data, we initially perform a Western blot analysis, and in fact, we were not able to detect ACE2 expression in our human astrocytes in vitro, but these cells that we have used, these human astrocytes, they express a lot of NRP1, so indicating that maybe NRP1 could be a receptor for SARS-CoV-2 in astrocytes. And try to test this hypothesis, we use an antibody against NRP1, and we were able to show that while astrocytes are infected by SARS-CoV-2, as you can see here, astrocytes that were treated with a neutralizing antibody against NRP1, they were resistant to be infected with SARS-CoV-2, indicating that probably NRP1 is the receptor for SARS-CoV-2 in astrocytes. And this data was also confirmed when we have used a chimeric VSV expressing SARS-CoV-2 spike protein. So the final question that we have was, what is the consequence? What does SARS-CoV-2 do to alter the brain? What SARS-CoV-2 do in astrocytes to cause change in the brain? So initially, using another approach, we infect astrocytes in vitro, and we perform a proteomic analysis of these astrocytes. So we were able to find that there is a different change in protein expression in these infected astrocytes. More than 200 proteins were changed their expression, were upregulated and downregulated. And when we analyze this protein expression, we were able to find that the main proteins that were changed in the brain, in the astrocytes, infected astrocytes with SARS-CoV-2, were protein related to cell metabolism. So, and when we analyze the brain samples from human with COVID-19, and we analyze the protein change in this brain, we are also able to find that there is a lot of proteins related to cell metabolism that could be important for the infection of astrocytes by SARS-CoV-2. And of course, it's well known that one of important function of astrocytes in the central nervous system is that because astrocytes can fool neurons with different cell metabolites. For example, astrocytes can produce lactate, and this lactate can be used by neurons to give energy to these neurons and can maintain the function of neurons. So since we have detected that the main change in the astrocytes caused by SARS-CoV-2 infection, we decide to analyze what happens with these metabolites, what happened with these carbon metabolites and these glycolysis metabolites after SARS-CoV-2 infection in astrocytes. So we decide to infect astrocytes again in vitro, and you perform a metabolomic analysis. And what we found is that when astrocytes are infected with SARS-CoV-2 in vitro, there is a reduction in the production of main important metabolites, for example, pyruvate and also lactate. There is a reduction in the production of these metabolites, and probably this reduction in these important metabolites can cause a change in the neuronal function in the central nervous system. So finally, there is also some evidence that activated astrocytes can also produce some unrecognized mediators or metabolites or compounds or mediators that can cause, for example, neuronal death. So we decide to see if the infection of astrocytes with SARS-CoV-2 can lead to the production of some mediators that could change neuronal viability. So for that, we infect astrocytes in vitro, and 24 hours after this infection, we took the supernatant of this culture and transfer for another culture of neurons, different neurons, SH culture, and also neurons derived from iPSCs. And what we found is that when we used astrocytes-derived medium from infected astrocytes, we can observe that this medium can cause and can enhance the death of neurons, suggesting that astrocytes infected with SARS-CoV-2 can lead to the production of some mediators that can reduce the viability of neurons. And these findings could explain why neurons, there is a dysfunction in the central nervous system, and maybe could explain this damage caused by SARS-CoV-2 infection. So as a take-home message, our lab were able to demonstrate for the first time that SARS-CoV-2 is able to reach the brain of COVID-19 patients, and also that this infection of the brain, we can observe that the main cells in the central nervous system infected by SARS-CoV-2 is astrocytes, and also that astrocytes infection that could lead to a reduction in the viability of neurons in the central nervous system. So this is our take-home message. I'd like to thank our collaborators and our students that perform these experiments, especially these three postdocs in our lab and also in the lab of our collaborators, Fernanda, Victor, and Flavio, and also our main collaborators, especially Danielle, Marcelo, and Clarissa. Clarissa that did these experiments in the patients, and also Danielle that is a specialist in iPSCs, and also other collaborators, and also the financial support that we received from FAPESP and also from SANPIC. So thank you very much for your attention, and I'm open for questions.
Hello, everybody. It's a real pleasure to be with you today to give a lecture on long COVID. I'm Serge Perrault. I'm a rheumatologist and a pain physician. I'm heading a pain center in Paris, France. This pain center is dedicated to musculoskeletal pain. And during this pandemic, we are now facing an increasing number of patients that are visiting our center for chronic pain, fatigue, cognitive dysfunction, that is very close to fibromyalgia. And I would like to share with you my thoughts about this new spectrum of disease, the long COVID, and to see what are the relationship with fibromyalgia, and is this a new fibromyalgia-like condition? Here are my disclosures on this topic with some advisory boards. And I'd like to present to you this case vignette that will be very familiar for you. It's a 45-year-old man that had a COVID-19 infection during 2 weeks with classical symptoms like fever, myalgia, fatigue, respiratory symptoms. And after that, he fully recovered, but he's still experiencing some symptoms. And 3 months later, he's visiting his GP for some symptoms: fatigue, shortness of breath, dizziness, sleep disorders, anxiety, memory loss, and also pain in different parts of the body. There are some blood tests and different investigations that are performed, and everything is normal. So while no abnormality has been detected, the GP is considering the reality of the case. Is this real? Is it something that is in the brain of the patient? Is it something that is close to fibromyalgia? These are the different questions the GP is asking, and is referring the patient to our center to get more details and more investigation for the diagnosis. In fact, this is really the symptoms of long COVID and also long haulers that has been used to identify patients who have symptoms that are, even if they have recovered from the illness after weeks or months. Although the acute symptoms of COVID-19 have been widely described, the longer-term effects are less well known because of the relatively short history of the pandemics. Symptoms that the patients are experiencing may be due to perhaps persistent chronic inflammation, but also sequelae of organ damage, but also the hospitalization, for example, in intensive care unit, and social isolation may also cause muscle wasting, malnutrition, and some sequelae. This was a little bit confused, but now there's a very interesting definition of the case that is very helpful for clinicians and researchers, that is called the post-acute sequelae of COVID-19 syndrome, the PASC. And this PASC, this very well-defined now condition, is now clearly recognized and is now something that will be helpful for the patient as a recognition of the disease, but also for the clinician to follow this patient and to propose some specific management. This PASC is complex, and also complex because there are lots of symptoms, many subjective symptoms, and here is a systematic review of 45 studies demonstrating the symptoms of patients with persisting symptoms after COVID-19 acute infection. And you can see that around 73% of the patients have more than one persisting symptoms after 3 months. This is important, and here you can see that the more important symptoms that are persisting are dyspnea, fatigue, also anosmia, but at the end you can see that also around 50% of the patient have still general pain that is persisting together with memory loss. This is from 45 studies on persisting symptoms after COVID-19. And it represents a huge number of patients, around 10,000 patients. What are the clinical manifestations of this new syndrome? It's multiple. It's, of course, in the brain with brain fog, dizziness, anxiety, depression, insomnia, and headache, but it may also involve lots of area of the body with abdominal cramping, diarrhea, chest pain, dyspnea, arthralgia, general weakness, and also in some cases persisting anosmia and dysgeusia. This is complex because this patient will visit number of physicians, number of specialists with difficult coordination together within all these specialists. Lots of clinical manifestation. And what is the frequency of this manifestation? It seems that fatigue is the most frequent symptom in this patient, with more than 30% of the patients that have severe fatigue with an important impact on their daily life, but also anxiety, sleep disturbances, headache, memory and concentration impairment. And in around 15% of the cases, myalgia, diffuse myalgia, that also may impair function in the daily life. These symptoms are persisting up to 9 months, but probably more. The pandemic is really recent, so we don't have a very long follow-up of this patient. The longer follow-up of the patients in the studies that have been published is 1 year. And it seems here in the study that again, fatigue, loss of taste, dyspnea, all these primary symptoms will be combined with additional symptoms that along the story of the disease are coming, not immediately, but after a few weeks. So myalgia, arthralgia, chest pain, throat pain, all these symptoms are occurring along the evolution of the patient and even after acute COVID-19 infection. And these additional symptoms can be severe in some cases, like throat pain, myalgia, and difficulty concentration. The question of this new symptom, this new syndrome, the PASC, you can see that pain, fatigue, memory loss, cognitive dysfunction, sleep disorders are really the core set of this syndrome. And this is really very close to what we are observing in fibromyalgia, in chronic fatigue syndrome. But what it seems that in PASC, what is more prevalent is dyspnea, shortness of breath, probably related to the initial viral infection, in adaptation to exercise and movement, and especially also dyspnea related to exercise and movement. Fatigue is perhaps more prevalent and more severe than in fibromyalgia, and also dysautonomic abnormalities have been found more frequently than compared to fibromyalgia. Here you can look at the chronic fatigue syndrome criteria, where lots of patients with long COVID or PASC can be diagnosed. You can see that all these criteria may apply to a patient with long COVID, headache, muscle pain, and refreshing sleep and fatigue, but also fibromyalgia criteria can be found in many patients with long COVID. Here is the widespread pain that can be diffuse with involving lots of area of the body, but also symptoms, a side pain, a side diffuse pain. This is the core symptoms of fibromyalgia. A side pain is fatigue, waking and refreshed, and cognitive symptoms. Exactly what we found in long COVID patients. So, and associated to these core symptoms, there are other symptoms, lots of symptoms in fibromyalgia that again you can find in PASC, like chest pain, headache, muscle weakness, fatigue, and all these symptoms that are incorporated in the new 2016 fibromyalgia criteria. And these new criteria for fibromyalgia are really interesting because they combine pain, general pain, but also these symptoms that should be present for at least 3 months. And a diagnosis of fibromyalgia is not excluding the presence of other clinically important illnesses. And in this new concept of fibromyalgia, the concept of fibromyalgianess has emerged as the severity of the fibromyalgia symptoms. What is the fibromyalgia symptom scale? Is the combination of the score of pain, the widespread pain index, and the severity symptoms, fatigue, cognitive dysfunction, and waking and refresh. And this is making a score. And with this score, you can define the fibromyalgianess. And probably the patients with long COVID or PASC have some fibromyalgianess with a score from 0 to 31. And along this line, they may, perhaps along the story of their disease, develop a kind of fibromyalgianess that we will try to treat and to help them to recover from this very severe disease that is COVID-19 in these cases. What are the pathophysiological hypotheses of this disease? Different hypotheses have emerged: nociplasticity, persistent viral infection, other viral infection, post-traumatic syndrome, or immune reaction. The concept of nociplasticity is really interesting for fibromyalgia. It means that in the brain and in the pain modulation, there's an abnormal pain processing that may be caused by infection, by psychological, physiological, physical trauma, and the fact that COVID-19 is a virus that has a neurotropic that goes to the central nervous system is probably very important for fatigue and diffuse pain. So probably there's a central nervous system inflammation triggered by the virus, and that may cause nociplasticity in this patient and this long COVID. Another hypothesis is reactivation of some viruses and co-infections by virus. We know that EBV, Epstein-Barr virus infection, causes fatigue, causes memory loss and pain. And here in this study, the this study demonstrated that there was a relationship between the Epstein virus antigen antibody and the duration of COVID symptoms after acute infection by COVID. So the longer the symptoms are, the higher we may found reactivation of EBV. So perhaps co-infection may explain these symptoms in some subset of patients. Also, immune modification have been suspected in some patients. Here you can see this study on patients followed after acute COVID infection. You can see initial symptoms and residual features after 152 days. And you can see that after more than 152 days, there are lots of symptoms that are still active, but there are also some symptoms that have emerged, like burning pain, paresthesia, cephalalgia, that were not found in the beginning of the disease, but after a few weeks of evolution, burning pain, paresthesia are occurring in these patients. And in this study, authors have tried to compare patients with immunized status versus COVID compared to non-immunized patients with lack of antibody versus COVID COV2 virus, and they were able to demonstrate that there was no difference according to the symptoms in patients that develop immunization against the virus versus patients that do not demonstrate any immunogenicity versus the virus. So immune reactions do not modify the symptoms and the spectrum of the symptoms. Another very interesting study is the study involving a lot of patients from Chinese authors that have looked at the risk factors for different symptoms, different persisting symptoms. And they looked at the risk factors for fatigue and the risk factor for anxiety or depression persisting in patients after COVID-19 acute infection. And they were able to demonstrate that sex women patients have more fatigue or muscle weakness, but also the treatment the patient had during their acute infection was also a risk factor. And they found that steroid administration was associated with increasing risk for fatigue or muscle weakness after weeks. This is perhaps related to the mode of action of steroids on the muscles, but also related to more severe patients that were treated by steroids during their hospitalization. For anxiety and depression, again, women were more anxious or depressed after COVID-19 infection. And also, but here, the steroids injection and the treatment did not get any difference in the persisting symptoms. How to manage this patient? And in fact, here, the fibromyalgia EULAR guidelines are very useful to manage this patient that we have more and more in our pain centers. first of all, the first step for this patient after this long story, the difficulty of the diagnosis, is to recognize the patient and the disease, to explain why after a few weeks, these patients are still experiencing very important and severe symptoms, even if the infection is resolved. So this, the name of PASC, this post-acute sequelae, is very important to consider. This is not active, this is sequelae, even if the sequelae are very severe. So diagnosing PASC, educating the patient, but also all the colleagues and the doctors is very important. And first, do not try to give them medication, but try to rehabilitate the patient, give some exercise, physical therapy is really important as a first step. The second step is to adapt the treatment to the patient's severity according to fatigue, according to psychological distress and other symptoms. And in this case, we will propose cognitive behavioral therapy, pharmacotherapy, other drugs according to the severity of the symptoms, as you can see in fibromyalgia. And again, we will adapt the management to the severity with this approach, analgesics, psychological, physical, social support, together with different actors, different healthcare professionals like pain specialists, psychologists, occupational therapists, physical therapists. This should be adapted to the severity. And lastly, here is very interesting paper to consider the methodological recommendations for further studies on persistent COVID-19 symptoms, because when you look at the literature, this is very confusing. There's a heterogeneity in the studies and patients are not comparable in the study. So these are really interesting to guide the future studies on this PASC, to include patients, to comparable patients, to get more information from the future study. To conclude, I would say that PASC, post-acute sequela of COVID-19 infection, is really a new context of fibromyalgia and chronic fatigue syndrome diseases. It should be considered the same as a syndrome that is not related to an active disease, underlying disease, but more as a sequela. And these sequelae are real. We should recognize the patient in this disease, in his symptoms. We should reassure the patient that he will recover. We don't know when and how long it will last, but he will recover after a long-term multimodal approach according to the severity of the symptoms. And lastly, more recently, we have found after vaccination of some patients, a kind of PASC syndrome that is probably rare, but we should also consider that after vaccination, some patients will develop some kind of pain, fatigue, and long-lasting symptoms that are also close to long COVID. So the story is not finished, but this is really exciting because now in a very short time we've learned a lot about this new disease, about the patient, about the management of this patient. And I think that future study are still needed to be more helpful and more effective to treat our patient. I thank you for your attention, and I remain available for any question.
Well, welcome back. I hope you enjoyed all the talks from our wonderful speakers. And we'd be happy to take some of your questions now. There's been questions in the text box. This first question asks, as we see muscle pain, myalgias after COVID-19 is very common. Is it more likely myofascial pain syndrome after COVID-19 is what people are seeing if it doesn't meet criteria for fibromyalgia? Serge?
Yes, so in fact, this is more myofascial pain. Myofascial pain is not so frequent. It is more fibromyalgia with more diffuse pain and not localized pain. So, but in fact, this is not myofascial pain, definitely.
So another question from the audience. Can we please comment on the function of NRP1 receptors and why they are present in astrocytes?
Yeah, it's. I think this question is for me. And yeah, the NRP1 it's a co-receptor for VEGF, which is a vascular growth factor, vascular endothelial growth factor. There is some data explain what's the role, but it's a kind of co-receptor that is needed for the signaling by this molecule, the VEGF. So, but why this is expressed in astrocytes? Nobody knows exactly what's the role of this protein.
Thank you. I'm going to take this question here. I think we have a virologist, and he might be a very good one to answer this. Do we know whether the brain changes identified are going to be exclusive to COVID-19, or do we think that these are going to be present in other viral infections as well?
Do you want me to take that, Brian?
Yeah, I think so.
Okay. I think that there will be some changes that are going to be specific and others that won't be. One of the things that's intriguing about this virus is that the receptor it uses is present in vasculature, which means that you have strokes, for example, other kinds of thrombotic events. These are not typically seen in most viral infections. On the other hand, some of the findings that we have that are particularly robust are associated with cytokine elevations, which are present in a wide range of different types of infections. And those are going to be more promiscuous. And those are probably likely to be the most important. Now, Serge has talked a little bit about reactivation of herpes viruses like EBV. And many of these patients do have a presentation that could be similar to mononucleosis. I think that the number of people in whom we're going to see those kinds of reactivations is going to be modest, but they'll be important to recognize because they will be treatable with anti-herpes drugs. Over.
Thank you. All right, there are two questions that are kind of similar. I'm going to try to squish them into one. There's a question about astrocyte susceptibility to COVID, to SARS-CoV-2, leading to astrocyte cell death. And there's a similar question asking about the long-term consequences of infected SARS astrocytes. So what can we expect to happen over time because of the susceptibility that you've seen, Thiago?
Yes, yeah, we saw some evidence of astrocytes death. Probably because there is this replication of SARS-CoV-2 inside the astrocytes, but it's not so high using very high MOI infection. What we don't know is that after replication, if these SARS-CoV-2 can leave the astrocytes, can leave the cell. So we believe that there is what we call abortive replication. So they start to replicate inside astrocytes, and they can promote change like reduction in the metabolic change inside the astrocyte that can compromise the neurons. And also this infection can drive the production of different molecules that can change the function, and that could also cause neuronal death. So yeah, so there is this evidence that there is a replication, but we think that the replication is not complete. There is an abortion replication in this astrocyte. So probably the effect on neurons are indirectly through molecules being produced by astrocytes, or even through the reduction in the metabolics that can be used by neurons coming from the astrocyte, infected astrocytes.
Thank you. An interesting question here. With the effects of the virus on the central nervous system, can we anticipate that some of those consequences may lead to other neurological conditions such as Parkinson's or different types of neurologic dementias? Anyone care to comment?
I'll comment if nobody else wants to do so. I think that there's a high risk that we will see acceleration of neurodegenerative disorders as a result of chronic inflammation, as well as structural damage associated with the vasculopathy. But that may not be immediately apparent. It may be something that we'll only appreciate over coming years. Over.
Thank you. Well, we're doing pretty good with these questions. Let's see here.
There's a question on gabapentinoid. I'm okay to answer.
So,
Yeah, when the
how about
pharmacological
that?
strategies are required for addressing. So it's when pharmacological strategies are required for addressing severe nociplastic pain syndromes post-COVID. What is the current evidence for the use of gabapentinoids? Serge.
Yeah. In fact, we already know that in fibromyalgia, for example, gabapentinoids are not working very well. The level of evidence is very weak. So, and the level of evidence is better, is stronger for exercise, and the work that Ayant showed about exercise and modification, I'm sure it may apply to this COVID-19 infection, and probably it's better to not to use pharmacological strategy, but more non-pharmacological strategy and mainly exercise. But if you want to use pharmacological strategy, I would not use gabapentinoid in this case. We know that there are already lots of fatigue, cognitive dysfunction, and probably gabapentinoid may when there are already cognitive dysfunction and fatigue and all these symptoms. So this is probably not the best pharmacological option in long COVID patients.
All right. Well, we'll take this moment to thank the audience for its attention. We hope that you enjoyed this session, and we will give you 1 minute of your lives back. Thank you so much, and we hope that you join us for session 3 in a little bit.